would like to tell you about the December issue of the JVS and some of the key articles. The first paper by Chandra and co-authors from Stanford, entitled Management and Outcomes of Symptomatic Abdominal Aortic Aneurysms During the Past 20 Years, compares symptomatic patients with AAAs, defined as those who had the new onset of abdominal pain or aneurysm tenderness, with no rupture found by CT scanner in the OR. In these patients, the repair of abdominal aortic aneurysms was primarily open from 1995 to 2004 and evolved to primarily an endovascular repair during the next decade. Decisions about the method of repair were surgeon-specific, but often based on the aneurysm's relationship to the renal arteries. 92% were infrarenal, 4% juxtarenal, and 4% pararenal. Patients who underwent either open surgery or endovascular repair had a similar mortality, but an open repair was associated with a significantly longer length of stay, more wound complications, and more delayed GI function. The authors concluded that symptomatic abdominal aortic aneurysms can be repaired well with either an endovascular or open approach. Complications are more frequent with an open approach, and symptomatic abdominal aortic aneurysms behave more like unruptured, asymptomatic aneurysms than ruptured abdominal aortic aneurysms with regard to mortality, even though symptomatic and ruptured abdominal aortic aneurysms have historically often been classified together. The next paper, Early Carotid Endarterectomy performed 2 to 5 days after the onset of neurologic symptoms, leads to comparable results to carotid endarterectomy performed at later time points by Avgerinos and co-authors, reported on data collected prospectively by the Vascular Study Group of New England. They found that symptomatic patients who underwent carotid surgery for TIA or stroke within 48 hours had a higher than acceptable 7.3% risk of procedure-related stroke, while carotid surgery after 2 days had a lower stroke rate of 3%, which was within national carotid surgery practice standards. The risk of a carotid procedure-related stroke was not higher when performed within 2 to 5 days, and not higher than it was when performed later. Therefore, the authors recommended early surgery after 48 hours in stable symptomatic patients to avoid the risk of a second TIA or stroke while waiting for a prescribed time for initial symptoms to resolve or improve. We would strongly recommend that you read this paper as well as the invited commentary by Dr. Ashraf Mansour. Another excellent paper, Safety and Efficacy of Polyurethane Vascular Grafts for Early Hemodialysis Access, by Kakis and co-authors from Athens, Greece, reported on an arteriovenous graft made of polyurethane, which has the advantage of early cannulation, reducing the need for placement of a central venous catheter, and was performed in patients who needed long-term dialysis. They placed 125 straight brachial axillary grafts in patients and compared 64 of the polyurethane grafts with 61 of the traditionally used polytetrafluoroethylene or PTFE grafts. The time from implantation to use was 1 day in the polyurethane group and 28 days in the PTFE group. Polyurethane and PTFE had similar infection rates at 5 years, and none of the polyurethane group patients developed a pseudoaneurysm necessitating intervention. The median primary patency was similar in each graft at approximately 2 years, and they had similar secondary patencies. The authors concluded that polyurethane grafts offer the advantage of early cannulation with infection, pseudoaneurysm formation, and patency rates similar to those of PTFE grafts. The final paper reviewed today is by Schutze and colleagues from Texas, entitled Mid-Term and Long-Term Follow-Up in competitive athletes undergoing thoracic outlet decompression for neurogenic thoracic outlet syndrome. They reviewed the outcomes of athletes on whom they had performed first rib resection and scalenectomy. Between 2009 and 2014, 232 competitive athletes, both men and women, underwent surgery, and 67 responded to a survey at an average time of 3.9 years post-surgery. The most frequent sports requiring TOS surgery were baseball and softball, volleyball, and gymnastics. The survey revealed that 96% of patients were improved in pain medication use, 75% would undergo repeat first rib surgery on the other side if needed, and 82% had a resolution of symptoms, while 94% were able to perform activities of daily living without limitation. 70% of these athletes returned to the same or a better level of athletic activity after the surgery, and this occurred within 1 year in 50%. The authors concluded that the majority of male and female athletes are able to return to their former competitive state, and few experience limitations in their daily living activities. Half can return to competition at or exceeding their pre-morbid ability level within 6 months of surgery. We hope that you enjoy the December issue of the JVS, and thank you for your attention.